So in my view, these are not easy, but are critical issues to be dealt with if the health and care services are to get through the next 5 years of funding restraint and steeply increasing demand in a good state, which is why this is the right debate to be in, rather than whatever the GPs are talking about along the corridor. Which is why I'm very much looking forward to the panel unpicking some of these issues and looking forward to us getting into the debate after that. So we have a panel of rich and varied perspectives to speak on the prevention agenda, and particularly pleased to introduce our first speaker, Andrea Jenkins MP, a new MP in May, was one of the big stories of election night, as people know, overturning Ed Balls' majority in Morley and Outwood in Yorkshire. And she, I believe, has a strong interest in patient safety, in particular in relation to the NHS, and one of the drivers for you to coming into politics. Also, of course, patient safety, a big interest of Jeremy Hunt, Health Secretary. And I think you've became an MP in May, but already established a all-party parliamentary group on patient safety, I believe. Seems like a fast movement. And so, Andrea, you have going to give us a few minutes to get us started on prevention.
Well, I'll stand up because I like to see people's faces. So. Thank you very much, Dave. Now, according to the King's Fund, there's 15 million people living with a chronic condition in the UK, and that's expected to rise by a third by 2021. So I think I'd like to congratulate you for actually bringing this to the table. You know, it's very timely, and it's a very important issue, really. So now, before I start, there's a bit of a caveat. I'm not an expert on health. I see myself more as a layman, as a newly elected politician. I got into the sort of the health agenda after losing my father. Now, I've always looked at the patient perspective, really. And my dad, he actually went into hospital to have his lungs drained, and various things happened, and what shouldn't have happened in the process, and he caught MRSA, a hospital infection, and died. But it was sort of like the lack of care, really, the lack of hygiene, and I suppose the lack of awareness, really. And I think awareness is a big thing, really. Information and access to data is a big thing in this whole debate, really. Now, long-term health conditions account for over 70% of the primary and acute budget in England, and regarding access to information, I think it can be positive and it can be negative. I myself have got a couple of chronic conditions. I've got fibromyalgia, had it for 10 years. My sister's got MS, diabetic, she always injects herself after every meal. But to me, I know a few people with the conditions, and I think it's a state of mind as well. And I think sometimes when people Google things, they can make themselves feel worse. This is sort of in my experience. I know my middle sister's a bit of a hypochondriac. She goes to the doctor so many times unnecessarily, and so I think access to information is important, because on one point it can make people probably too paranoid, but on the other side, access to information is very good for early diagnosis as well. Now, I think we need to sort of turn IT and technology on its head and use it as a way to actually really inject life into the health system, really. And if I just can talk briefly about, I also set up an all-parliamentary group on the town centre in High Street, because I'm an ex-retailer, and whereby we look at the internet as, you know, pulling footfall away from the high street and killing our high street, that just becomes pound shops and charity shops. Again, we need to turn that on its head and look how can we drive footfall in the town using the internet. I think it's the same here, really. You know, what can we do to help with early diagnosis? Now, I come up with a bit of a slogan, which I just took to Jeremy Hunt. Can you imagine children, they all like taking selfies, don't they? Yeah, and teenagers. Can you imagine if there's a way that we can actually get children to look at what they're eating at the moment, what are their exercise levels, have they got sedentary lifestyle? And so they can actually take I call it my future selfie. Kind of take a picture, enter their data into a computer, and what comes out is actually, if they don't change their the way of looking and take responsibility, really, for their own well-being, then what they're going to look like in the future. So what is their future self? So, I mean, we all know that we've got an ageing and expanding population, and what concerns me really is that we're going to need a never-ending pot of money to make the NHS sustainable, really. And so I do think it's probably going to be a generational change in order to actually get people thinking differently. I mean, I think we've got to a society now where we probably, in life in general, where a lot of people expect you to do things for them. So I think it's changing that mindset in all the lives, really. I mean, I'm sure there's a few people who's over 40 here, like I am, where I remember parents, you know, if you fell over at school or when you're with them, come on, pick yourself up. You know, if you got a common cold, deal with it with home remedies, really. And I think we've gone a long way from that now, really. And if we take antibiotics, the overprescription of antibiotics, and that is antimicrobial resistance is on the global agenda now, thanks to Dame Sally Davis, the Chief Medical Officer, and also our Prime Minister David Cameron. They took it to the World Health Organization. The overprescription of antibiotics is a major problem as well, because you know we can't fight off the infections. I know that personally from my dad, really. And so I think changing people's mindset is going to be a major thing in this information age that we're living, really, and taking responsibility for their lives, really. I mean, if you think of IT, and I'm focusing on IT, but it can be used in a positive way. Look at the Wii Fit, and how many people here have actually got the counter on their iPhone, which says you how many steps you've made a day. Anybody here? Yes? Well, I can tell you it's between 12 and 14,000 steps a day in Parliament, so that's what I found out since being a newbie. But I also spoke to a few family members, because I'm an auntie 9 times, and I spoke to a few family members, my nieces and nephews, and really spoke about the IT, and they do seem to lead a lot more sedate lifestyles, really. And where I'd be sort of like going out and playing on my bike, you know, I mean, some of the comments I got back was, look, why go around to your mates when you can talk up over the network or over your Xbox, yeah? And why wander around to hail a taxi when you can use Uber? Why walk when there's an app telling you that there's a bus what's 2 minutes faster? So again, we need to turn technology back on its head, I feel, really. Now, I've spoken to Jeremy Hunt on really about my future self, really, and what can we do, and I'm very pleased to hear that, you know, in the autumn we're going to bring out a discussion about childhood obesity and a whole campaign on what can we do to tackle this. So I think that's good news, really. We need to start at that young age with education, really. And I mean, I'd personally like to see, you know, I think it's all our responsibilities, you know, from whether it's parents, you know, our peers among us, siblings, parents, teachers, and also GPs. I think if collectively we need to tackle this, we can't always just assume that it's going to be the health service doing it. So I think we all need to take responsibility, you know, for sorting this out, really. I mean, the 5-year government forward plan, there's some pretty grim statistics. Less than 1 in 10 children who go into reception are obese. In primary school, that doubles to 1 in 5. 1 in 5 adults still smoke, and 1 in 3 still drink too much more over the limit. So what is it we can do, really? I think, as I said, it's all about the mindset and getting people to really look at themselves and take responsibility for their own lives. It's, as I've just alluded to, I think it's the IT and information age as well, and it's but it's also looking at long-term health conditions and what can we do with early diagnosis, really. I mean, I wonder whether we will get to the stage where not only can we diagnose things online, but do we use video conferencing in some instances with our GPs? No, I think there's a way we can see this as an opportunity to be really innovative, really, and it is a bit of a ticking time bomb, really, and so I think we ought to really step up to the mark by looking how can we innovate to make the most and solve this problem. So that's it. I'm happy to take questions a bit later as well. So yeah. Now I'll hand you over to the real experts now. So. Thank you.
Okay, thanks very much. Plenty of food for thought there. So John Giles is going to speak next, Medical Director of Benenden Health and Benenden Hospital since 2012, I think. Yeah. Excellent. consultant radiologist by background, and so Benenden, for those not familiar with Benenden, is a mutual independent health provider and insurer, and has been a vocal champion of the mutual role in the health service and of prevention, well-being and integrated services. John, to you.
Thank you very much. Well, that was fascinating listening to it. You could have written my speech for me.
Oh,
Some
really?
of the points you made there. There's a lot of resonance there. I think everybody agrees that the NHS is facing some enormous problems. I've been a consultant for longer than I care to imagine, but throughout my professional career, including of being a hospital porter for 12 months and 5 years as a medical student, it's always been like that. It's nothing new. But I think the scale of the problems now and how we provide healthcare will be greater now than any time in our history. From its inception 60 years ago, the NHS has grown year on year, and it's lurched from one crisis to another. Every time there's a new solution, every time there's a new problem, a solution comes along, there's unintended consequences from that solution. Now, don't get me wrong, I'm a big supporter of the NHS. I still work in it now, and I've worked in it all my career. And it is without doubt probably the most cost-effective means of pooling risk and providing basic medical services. But the problem is one size does not fit all. And by trying to impose a unified model on everybody, you're going to have a lot of people who are not going to fit the bill and are going to be dissatisfied. Each individual is different. We've already heard about population growth, changing demographics, aging, and the increased prevalence of chronic disease. And they're going to continue to place enormous burdens on NHS services. Life expectancy has increased from 76 to 81 since 1990. That's another 5 years of life expectancy, which is to be embraced. However, that is going to cost it's almost £10,000 per year for additional healthcare for that age group alone. Where is that money going to come from? That compares to the average £1,000 up to the age of about 60. Medical advances have led not only to improved survival and a better quality of life, which we all know about, but it's led to greater expectations. A lot of what we do now, it wasn't envisaged, it wasn't dreamt about when the NHS was first brought into being. Things we now take for granted: coronary bypass surgery, joint replacement, cancer therapies, my own speciality of imaging. It just wasn't there 60 years ago. We also have to try and wonder, why are 50% of the population taking regular prescription drugs? Is that right? I don't know. Is that prevention? I don't know. Do we have to medicalise everything? The obese, which I'm going to talk about more, are far more likely to need prescription drugs, many of which are a substitute for healthier lifestyles. They have high blood pressure, they have a high cholesterol, they have pain from joints, they're taking analgesics, they're taking statins, they're taking treatment for their blood pressure. A recent survey we did at Benenden clearly demonstrated that we as a society and the ultimate end user of healthcare have a very poor understanding of cost, and yet we expect the NHS to be there and pick up the pieces. Whether the illness is unavoidable and just bad luck, or whether it's the result of our own poor lifestyle choices. The same survey also said that the public thought that patients suffering from lifestyle-related conditions perhaps ought to make a greater contribution to the costs incurred from treating those. Recent research has shown that 40% of NHS resources are spent dealing with preventable risk factors. That's smoking, alcohol, and particularly diet. And this is a study by Public Health England found that 11% of ill health and early death was related to tobacco, almost 10% due to obesity, 8% high blood pressure, and 5% alcohol and drugs. Now obviously the Treasury gets a lot of money in from taxes, so £20 billion a year, that's a fifth of the NHS budget, comes from alcohol and tobacco taxation. So they are in some way contributing to the costs. Not quite so with obesity. We also know that there are huge regional differences in life expectancy correlating with deprivation. Men in the wealthiest parts of the UK can expect to live maybe 8 years longer than those in deprived areas. That gap hasn't changed since 1990. Perhaps it's not unreasonable that those who can afford to pay more should pay a little bit more for healthcare. But somehow we're going to have to try and find the resources to plug the £30 billion gap predicted. We've got 8 billion which has been earmarked already. We've still got another 22 to go. We can't just keep throwing money at it. It's not going to work. Somehow we've got to try and get the individual or groups of individuals to start and take a greater responsibility for themselves. And I think that's where the mutual model comes in. So it's organisations, a bit like Benenden, here's the plug, which are owned by the members, providing services for the members, not for private industry, not for private equity, not for companies, but they're doing it for themselves. So any resources they've got are reinvested for their own benefit. The democratic nature means that they can allocate those resources in a way which they feel is more suitable for their own needs. So that brings if you like, the decisions about healthcare much closer to the individual, not being taken by people in sort of ivory towers or mindless, the distant commissioning groups, which are a world away from the man in the street. They also provide a very cost-effective means to provide a range of services, some of which may be available on the NHS, but equally some of them may not be available on the NHS. But the members can prioritise how they want to spend their money. Now, there isn't any easy or right answer. Yes, in the short term we can keep throwing more money at it, but it's very difficult to track that. We can invest in little bits here and there. The public is pretty clear that it doesn't want to pay more tax, and perhaps they don't want to pay more tax for something which they increasingly take for granted or perhaps don't value as much. Why do I want to pay more for it? I don't know how much it costs anyway. People who work in the NHS, like myself, we can try and make efficiency savings. There's a lot of noise made about that. We've been making efficiency savings for as long as I can remember. There's only so much you can do, and I think efficiency savings is often just repackaging and rebranding services so you can get extra money diverted at a particular target that month. Like management by balloon, that's a problem, let's put some more money at it. Or let's put all these other problems in that problem. We can solve it. Mutuals aren't a threat to the NHS. They're liked by the members. I've just been to the BMA and RCN meeting a few moments ago. I know it was a bit depressing because it was really more of the same. Staffing problems, morale, better commissioning, integrating health and social care. It isn't going to address the personal responsibility which we've all got to take. Somehow we've got to do something about it. And trying to save the NHS in its current form is not going to solve the problems facing us. I think in the current political climate, we have a once in a generation to discuss as a society how we want our healthcare delivered, and more importantly, how are we going to pay for it.
Thank you, John. Well done for contending with what was thankfully a short video. So our third speaker this evening is Alex Fox, Chief Executive of Shared Lives Plus, a charity based in Liverpool which represents the interests of family-based and very small providers of care and support to older and disabled people. More widely, Alex is a champion for the role of local enterprise in care, I think, and for working with local authorities to promote that, and a champion more widely of personalisation in care. So, Alex.
Thank you. We're coming at this issue of prevention from some quite different angles, and my background's very much in adult social care. But I think whenever a group of people get together in a room and talk about health and care, they all agree on two things. One is that we need a more preventative system, and the other is that we constantly fail to get a more preventative system. And we have been trying for decades to shove resources upstream with no noticeable success, or when we do, they tend to gravitate inevitably downstream again. And we tend to see that failure as unfortunate but inevitable, like rain in Manchester. But it's not. It's actually a choice that we made. It's a choice that we make about the legacy that we have. We do have an organisation or a health system that was created many years ago for a completely different set of challenges, and we've inherited that. But actually, I believe we constantly make choices that keep our system in crisis reaction mode, and I think it's important to think about what those choices are and understand them, and perhaps make some different ones in future. So I think the first thing to recognise is that prevention is such an abused term it's almost meaningless. I led on prevention and early intervention for the engagement process that led up to the care white paper, and we couldn't get anybody to tell us in a way that made any sense really what prevention was, or certainly not any two people to agree. Often we were unclear about what we were supposed to be preventing for whom and how we'd know when we prevented it or not. So it's a term that is much abused. Some things that are labelled preventative services just look a bit like normal services. They're just a bit cheaper and a bit lighter touch. And actually some act inadvertently as funnels into service land. They take people towards dependence and services more quickly rather than helping people stay strong and independent and resilient. Which isn't to say that there aren't things which are genuinely preventative, and I'll come on to that in a minute. But that term is problematic, and there's no point in getting away from that. And actually, I think even more fundamentally, the way that we divide, not just in health and social care, but in a number of public services, we like to divide the world up into the preventative and the reactive. The preventative being what happens early on in the system, out there in community. It's got a great deal to do with what families and volunteers and communities and neighbours do. And people who are successful and have big, powerful public sector jobs have a tendency to see all of that as slightly mysterious and not the sort of stuff that they should sensibly be spending large amounts of money on, because the track record there isn't very good. So we have that preventative end of the system, and then we have the crisis reaction, acute end, where the real business of health and care takes place, where the money is, and as a result, where those power bases and those powerful jobs and those very big buildings are. And I think we need to see our continuing crisis reaction and an anti-preventative system in some of those politicized terms. We need to think about the structures that keep that system in stasis. So what's the alternative to that? There are some things that genuinely prevent bad things from happening. And they do that broadly by helping people to build resilience. There are interventions, and actually there are probably more accurately, there are ways of doing any kind of health and care intervention which empower people, which give people, citizens, families, the access to information, to resources, to emergency backup, to expertise when they need it, that empower them and that make them more resilient. And there are interventions and ways of doing interventions that connect people as well to each other, which is one of the key indicators of resilience. And when we start thinking about public service delivery in terms of not just does it deal with a particular condition or a particular illness, but does it help people build resilience? It allows you to stop thinking about prevention, because actually that's a way of thinking that's as relevant at end-of-life care as it is at early intervention. It certainly allows us to unmoor these two terms that we tend to bundle up together, the idea of doing things early and doing things which prevent something from getting worse or a problem from arising. So two brief examples of that. At that early lighter touch end, local area coordination is an approach to people who have not yet developed significant social care needs but are at risk of doing so, often isolated older people, for instance. It's been tested very thoroughly in Australia, across the whole of Western Australia for about 25 years, and is now being adopted by a number of councils. And a local area coordinator is somebody who has as the name suggests, a very local patch. They have a largely open door, they have a lot of autonomy. They can spend bits and pieces of money if they need to, but they essentially have the time and space to get to know people, to get alongside them, and to not just understand what they need, but also what their goals are and what they can contribute. And by understanding what motivates people and what they want to achieve, and where they might be able to make connections with those around them, they reconnect them to their communities in ways which actually builds their resilience and is genuinely preventative. So that's at sort of the early end of things. I'm from Shared Lives Plus. Shared Lives is an approach to care and support for people with significant support needs. So across the UK there are 12,000 people using Shared Lives. About 2/3 of them are people with learning disabilities. The next biggest group are people with mental health problems, but there are also people with dementia, people recovering from stroke, other kinds of home from hospital care, and other groups. And the way it works, people from all kinds of backgrounds, including people who have no formal experience of health and care delivery, are recruited and go through a really rigorous approval process by their local scheme. And once they've been approved as a shared life carer, they're matched with an adult who needs support, and they share family and community life. So both parties make a positive choice to be together, and that can, for about half the people using Shared Lives, that means that they move in with their chosen shared life carer and live as part of the family. And Shared Life Carer gets some money for that. They're not volunteers, they are trained and paid, and they're part of a CQC regulated service. But there's no clocking on and clocking off. It's not that kind of arrangement. It's people talk about people being just part of the family, particularly when they've lived together for 35 years, as some have. For the other half, it's particularly so for people with dementia, they regularly visit their Shared Life Carer, but on the same basis as it's going to be a family visit in which people do something based on the fact that they both enjoyed perhaps doing the same things, and they've chosen to spend time together. So that's at the more kind of acute, as it were, end of the system, but it's a way of providing support with a structure and a framework around what happens, the best inspection results across the whole of regulated care, considerably lower cost, and it does that by combining social action with formal support. So those are innovations, local area coordination and shared lives. They're relatively small. And we have a tendency to keep that kind of thinking about resilience and holistic thinking in a box as an innovation or a pilot or other ways of making sure it doesn't become the mainstream. But actually, we need those approaches to become the mainstream. And I want to end with, if I may, with 3 very brief challenges for that, which I think we could put, based on the learning from things like shared lives, to the whole of health and care and actually public services more broadly. So the first is, are you future focused? So not are you preventative, but are you future focused? As well as reacting to whatever the presenting need is or the clinical issue, are you delivered in a way which is intended to increase that person's future resilience, not just react to what's just happened to them in the past? Secondly, are you integrated into communities? So we've got a lot of support which is labelled community care, which doesn't have any fear of community. It thinks community is a place when actually community is a set of relationships. It's the relationships we form around us. It's not a building. So is this a community service in the true sense of the word? And thirdly, what I've called the connection test, which is, as I said earlier, you can deliver any kind of intervention, whether it's shared lives, or whether it's surgery and all of the support that goes around an acute intervention, in a way which confuses people, which separates them either physically or through stigma from those around them, and in a way that disempowers them. Or you can deliver that in a way which informs them, which empowers them, and which connects them to those around them, and sees that as important. And I think if we could set ourselves those kinds of tests, actually we wouldn't have a system where more of what we did felt like prevention. We'd have a system in which everything we did felt like prevention. I think that's the only answer. Thank you.
Thanks, Alex. Okay, so we're here for debate, and I'll come on to questions from the floor in just a moment. I'm just going to open up by abusing the position with a question of my own, as ever, and a couple of Andrea has referred to public health issues. You referred to the plan that's being developed on childhood obesity, and several of us have discussed the issue of personal individual responsibility for lifestyle choices. Do you, as a conservative, how do you draw the line between those types of interventions, which lots of people in the public health world would call for, but many members of the public would describe the sort of nanny state going too far? There's plenty of examples sort of out there on the slate if politicians sort of wanted to go for them in terms of pricing, limits on TV advertising to children, and alcohol pricing and so on. Where do you draw the line on that?
It's a very good question. I mean, look at sugar. That's a big thing at the moment. So many diseases it's shown to result from it, and also obesity. So, but I do think, as both politicians, as a government, if there's some kind of public health risk linked to something, I think we have got a responsibility to highlight that, really. I don't think we'd be doing our job if we didn't do that. So I suppose that's the first thing. The second thing, I think, is leading by example as well. I think it's important as well. If I could just give an example of what I'm doing. Losing my dad through a hospital infection, hand hygiene is just one area which is important to stop the spread of infection. And I do think sort of like future-proofing ourselves, as you've also said, about being future-focused. and people taking responsibility for their lives. It needs to get to the stage where, you know, how it was wrong not to use your seatbelt, you know, and it's the same with hand hygiene. And so I'm on the 25th of November, which is the date that we buried my dad 4 years ago. I'm launching a big campaign, and what I'm trying to do is get politicians from all levels involved in this. I'm launching it in Parliament with MPs to go into their local schools, do hand washing training. Then I've got councillors going into care homes next year, MEPs involved. Then I'm going to do in a year's time a big public campaign on hand hygiene. So my whole point is, I think not only as a government, but I do think we need like leaders in the community as well to address issues like this. So wherever we are, you know, we're talking about the issue. I mean, with the campaign I'm doing with hand hygiene, trying to have also in the schools hand washing champions, and I think it's the same with health really. I mean, I'd love it to get to the stage where it's the third sector, it could be like an organisation like yourself really, and GPs, whoever, can go into schools and actually speak to pupils. You know, about the benefits of actually taking responsibility for your own health. I mean, when I was a counsellor, I did this thing called Role Model Day, where I'd bring people from the community, whether it was nurses, doctors, firemen, and they'd go and speak in the school assembly and just try to inspire the children and make them realise why, you know, education is a transferable skill that you can use in the working world as well. And I just would like to see a whole joined up approach. It's not just politicians, it's not just government, it's not just NHS workers. It's as I said earlier, it's a ticking time bomb. It's an issue what's affecting all of us, and I think we all need to pull together for it.
Okay. So yeah, we've got a good chunk of time for questions. Do you want gentleman there?
James Wedday from the College of Occupational Therapists. It's funny because you stole my question, Chair, so I can't ask that one.
Another one quick.
The sugar tax and legislation.
Yeah.
My other question was, I know it's a very complex issue, but in your view, panel, if you had to choose one reason for why, because obviously we've known for a number of years smoking too much, drinking too much, etc. is bad for our health and will lead to an early death, whatever. Why do people not adhere to a better lifestyle choices in doing simple things as in exercising, eating less, etc.? In your view, what would be the one thing stopping that? I know it's a complex issue, but just one reason or one thing that you think of.
I think convenience. That's probably the top thing, really. I mean, a lot of us lead quite hectic lifestyles now. You know, so many demands, whether it's family, work, or working longer hours. Really, we work a lot longer hours in the UK, don't we? Than some of the European countries. So I think it's convenience. You know, I mean, popping that quick microwavable dinner in the microwave, what's loaded with sugar and God knows how much salt. So. But I think it's education as well, making people realise that, you know, for an extra 10 or 15 minutes more, you can cook quite a decent meal with some vegetables. So convenience, I think, is a key thing for me. Time is the biggest factor in people's lives, that I think, which determines what they're going to do.
I agree with that to some extent, but I think one of the main reasons is that there is no feeling that there's going to be any consequences on the individual. It doesn't matter what I do because somebody will come and make it better for me. I can live a very unhealthy life, I'm still going to get my bypass grafting, I'm going to get my hips replaced, I'm going to get my joints done. It doesn't matter, it's not going to cost me, it's going to cost somebody else, and I'm entitled to it because I've paid into it.
Do you think the only way to address that is sort of charging and co-payments and access controls and so on, or are there other ways? The question's been asked as well about national public health interventions.
I think it's always going to be a question of carrots and sticks, and I mean you have to provide some carrots to encourage people to adopt healthy lifestyles. So there has to be some kind of benefit for them somehow. There also has to be consequences of people's poor choices. I mean, if you drink too much, you smoke too much, then you have to pay for it. You're paying through taxes. If you eat too much, it doesn't really matter. Then we get back to the idea of a sugar tax. We probably need something like that somewhere along the line. But somehow we have to try and make people more aware of the consequences to their own personal and financial future of their lifestyle choices. I'm all in favour of people being able to decide what it is they want to do. If people want to go off and smoke, that's up to them. They know it's going to kill them because it says so on the package. It doesn't say on the packet on the bottle of full fat Coke that it's going to kill you. Maybe it should.
So, running through all of our work is this idea of taking an asset-based approach to public services, which broadly is saying that if all you look for is what people can't do and what their problems are, that's all you'll find, and you always conclude that you need an outside expert to come and fix people. So I'm a big fan of the asset-based approach to public health, which is starting to take hold in the world of public health. We've thrown billions at essentially very loud lectures, I think, with the general public. We've thought if we just tell people clearly enough what the problems are, that will connect with them and that will change people's behaviour, and it works for some people. And it really doesn't work for some people, and there are people for whom those messages just don't connect and aren't going to. And probably some of the penalties that we could put in place also wouldn't actually necessarily connect as well. Whereas peer-led approaches to public health actually, in my view, are the things that work. So there isn't a single right answer to what's going to make an individual do something. It will depend on that particular individual and those around them, but that peer approach allows for that flexibility essentially. So if you look at organisations like Altogether Better and its Health Champions programme, they have really helped primary care in Pudsey and Leeds as well as elsewhere take a much more community development approach that genuinely connects with people, whereas in the past GPs had been struggling with sort of sending out messages and trying to get people to come in and talk to them, but they wanted them to talk about whatever it was that the GPs and the primary care staff thought was important, and they weren't finding what connected with people. So there is a GP practice in Leeds that has a licensed bar in it now, which is an interesting approach to public health. But their open mic nights are really popular, and they get a lot of people into that practice talking, at which point once they've gotten through the door, they kind of, in their view, that's the main issue. These people haven't just suddenly taken up drinking because they'd never come across it before. So I think that kind of peer approach, which is how I'd encourage your hand washing. How can we get young people to lead this actually?
Would you like to get involved?
I'm not young enough.
No, it's all ages, not just children.
But yeah.
Okay, thank you. Is there another question? Yes.
Yeah, I don't think we should.
Can you say where you're from?
Sorry, Derek Brooks, constituent, helper on Andrea's team in the past. I don't think we should give up on the effectiveness of trying to find better prevention. And I think key in that is GPs. You might face a lot of resistance from GPs. They claim that they're too overworked, they don't have enough time with patients. But a lot depends on their experience. And my issue with GPs is that they misdiagnose conditions, they misdiagnose completely, or give an incorrect diagnosis, perhaps through pride in their experience and so on. Some are very young GPs who don't have a lot of experience. Some rely heavily on experience for having done it for so many years. But taking Andrea's point, couldn't they use IT more? Someone presents with some symptoms, punch it into the system, and it gives a whole range of possible diagnoses for that person. And I've got a very personal issue on this, as Andrea knows. But, should GPs be less their experience and rely more on IT?
Yeah, people want to respond to that sort of role of not only GPs but sort of health professionals in prevention. I mean, you referred to the conflict between sort of prevention and sort of avoiding deterioration, I suppose. They're not always one and the same thing, but is this something that there is a greater role for health professionals in, or is it all about the individual?
I think it's a mixture of both, really. I mean, we're all human. I mean, can everybody here remember everything they learnt at university? Because I know I can't. Yeah, remember the interesting bits, don't you, really? Or the bits that resonate with you personally. So I think a mixture of both. I wouldn't like to see us completely, relying on technology. But I also am aware that, the human brain, we can't remember everything. And there's so many new diseases coming out now. So if there's a way of combining the two, that you can put the symptoms in, which will help aid the GPs and healthcare professionals to come up with a whole list of possibilities. Because I know in Derek's case, with his late wife, diagnosis is early diagnosis is the most important thing, really, to save someone's life. So I'd like to see a combination of both.
Okay. John, are you sort of persuaded of the role of decision? That
I think it's a very interesting question. I mean, medicine, of course, is one of the careers that's been flagged up as being at risk from artificial intelligence. I think if you put your symptoms into Dr. Google, it will come up with the right answer probably 80 or 90% of the time. But that one right answer will be amongst a list of 30 or 40 other conditions. Now, how are you going to pick out which one it is you've got from that list of 30 or 40? I think that's where you need the experience and the medical training and the, if you like, the knowledge of common things are common, rare things are rare. It's very easy to berate and kick GPs for not picking up things early. Yes, they might not diagnose cancers at an early time. However, you do have to think that, well, a lot of things that they do diagnose late, it might not have made that much difference if you diagnose it a little bit earlier. There are undoubtedly some things where early diagnosis makes a difference, but equally there are a lot of conditions where it doesn't. We already have pretty good systems in place to flag up people with so-called red flag symptoms, to fast track them for various cancer clinics and services. But most cancers are still diagnosed in the accident and emergency department because they don't fit that typical presentation. So I think it's very difficult. Yes, we need better access to diagnostics. We don't have enough radiologists, we don't have enough CT scanners, MRI scanners, etc. But it's very difficult to pick out one particular area where there are problems. It is an across-the-board holistic thing. And the other reason why we have poorer outcomes perhaps in cancer in this country, it's an attitude, it's the public's attitude. They tend to put off going to see the doctor because they tend to ignore a lot of the symptoms, and it gets back to education. People think they're going to go to the GP, it's going to be made better, they'll be referred on, the NHS will be there, they'll fix it, because that's what happens in Holby City. It's not real life, I'm afraid.
Okay, Alex.
Yeah, I think we want GPs to be miracle workers. In a 10-minute appointment, we want them to diagnose and fix a lot of medical issues, which often they are extremely good at doing. But then on top of that, we'd also like them to be able to use that 10 minutes to sort some really deep-rooted mental health problems, some social care problems, sometimes even some housing problems. And then in their spare time, we'd like them to sit on CCGs and commission the whole of healthcare. And some of my best friends are GPs. They are truly wonderful, lovely people, but I just don't think we should be resting everything on their shoulders. So in the Health Champions programme I was talking about, the key insight there is that actually there's a lot more in the community that GPs and primary care staff more generally could be drawing in. So they brought in the voluntary sector in a much more equal basis rather than sort of just occasionally going and asking if they could have a volunteer, and connected with people in a much deeper way. So drawing on IT I think is useful, but actually drawing on communities and the resources of communities I think is even more powerful.
Do you think politicians are wrong to be sort of still drawn, of all parties into commitments to sort of particular numbers of medical professionals? Just thinking of this concept we've all talked about of moving to a more preventative health service, yet the commitments are generally expressed in numbers of GPs rather than the types of work you're talking about.
I think that one's a little tricky for a non-political charity to answer in some ways, because we, regardless of whether you constructed the health service in the way that I'm suggesting or in any other way, I think some people will still feel that we are short of GPs. I'm not suggesting that if we worked in a much more kind of community-orientated way, we'd suddenly have GPs twiddling their thumbs. We'd have GPs who were still run off their feet, but just hopefully doing more of what they are good at doing. That's completely separate, I think, to a GP recruitment and a health, particularly social care funding crisis.
Okay.
Can I pick on that? I mean, GPs spend a lot of time doing things which is not general practice and not medicine. There's a lot of bureaucracy, they're running the practice, they're running the business, they're meeting various initiatives to try and get the right funding, they're having to ask people to screen for dementia, they're screening for high cholesterol. That's the first thing they do. Are you a smoker? What's your blood pressure? They're not really interested in why you come to see them. They've got a whole bunch of things to tick off first. And it's not just medicine, it happens in nursing as well. A lot of nursing now is driven by very bureaucratic tasks. And probably, as I read somewhere, about 21% of time is actually spent in direct patient care. The other 80% is doing something else.
I agree with both really, and I like Alex's point, as I said earlier, about bringing the third sector into it as well really. And I mean also why are we relying just on pill popping as well. I do think part of preventative care should also look at people's lifestyles and what natural ways is there to enhance people's lifestyles and well-being. Depression, encouraging, even getting a dog. Really, we've seen how having a pet can affect people's, depression, getting out in the fresh air. So I think we shouldn't always look at pill popping because I think that can mask a problem at times, really. And so I do think we need to look at outcomes and what's the best way and individualising that healthcare really, as you said earlier, not one size fits all.
Are you someone who sort of can stomach and sort of in favour of the stories about NHS money via personal health budgets being spent on things like pets and PlayStations and so forth, examples in the press?
I don't know if I'd necessarily go that far, but I do think the thing is that comes down to being informed as well. Are the people who's making the decisions informed to make the right choice? Or that shiny PlayStation might look like a good idea, but is that the best thing for them and their condition? So I do think it goes hand in hand with we've got to make sure the advice is there as well. Really.
Okay. So another question. Yes, at the back.
Adam Penwarden from Lifeways. I was just going to pick up on the point about PlayStations on the NHS. There's two things I think to remember about that story. First one is that those personal health budgets that people had allocated to them, and they made some choices. The second one is that story got in the press because the BMA did a freedom of information request. And my question to the panel is that you're not going to make this omelette without breaking quite a few eggs. And there's going to be a power shift if we're going to do this stuff. We spend £110 billion a year on the NHS and 14 billion on social care. We know we probably can't spend much more than that 124 billion. So where's it going to go? And I think my question is perhaps to the medical profession, but also to the political profession, which is that a lot of the ideas are very challenging in the sense they're going to mean a lot of change. And two things spring to mind. One is Alex's the idea of area-based. That raises the old spectre of the postcode lottery, and that is a challenge to politicians because I'm getting X in area A and I'm getting Y in area B. And the other side of it is it might mean that hospitals are going to close. And I guess my question to you as a politician is, is there the political courage for politicians not to join the Save Our Hospitals campaign and to say, actually, this is the best thing for the people in this area? And it's a genuine challenge, and it's a tough call, because I know there aren't many votes in Don't Save Our Hospitals.
And I think you've hit the nail on the head, really. I mean, the NHS, I think the general public and politicians as well, really, we're very protectionist.
Yeah.
And the thing with protectionists, you don't always innovate, really. And so I would like to see more of having that courage and trying something new and look, let's lead the way on something, really. So I'm much more for that. I think, as my dad used to say to me, dream big and dare to fail, but you always need a backup plan.
What about the issue that's raised about that balance between the sort of £110 billion NHS budget and sort of 14 billion reducing fairly quickly in real terms social care budget? Do you think that's wrong?
What, that the budgets?
That we're going to see in the next few years the NHS budget pretty much protected, and the social care spending continue to fall, even though we're talking about sort of non-medical and clinical approaches.
I mean, it's a difficult question because when you've only got a certain pot of money, and it probably comes into what you said earlier, really. It's when you're protectionist over something, I mean, would the public stomach spending less in the NHS? Let's face it. Would the press stomach spending less on the NHS? And or do we actually take hold of it, spend less and put it into adult social care? like, who knows? It's a difficult question, really. And as a new politician, one who hasn't necessarily got the answers.
Yeah.
But at the same time, we've got an ageing population, as we said, we've got an expanding. So I think to a certain degree, we have got to protect the NHS budget. So I think, as George Osborne announced in his Chancellor's speech today, that we're continuing to protect it. So I think that's right, and especially until we've got a hold on the situation, if we ever get a hold on the situation, really, to look for new innovative ways, really. I think we have got to protect it at the moment.
Okay, John, what's your take on that? So,
There's a lot of stuff I do in my day job which I think is probably a waste of time. But it's things which we are perhaps expected to do because there are various guidelines, targets, initiatives which have been written by very authoritative individuals and bodies, which are very much cover your ass type medicine, and a lot of imaging which is done is non-contributory to the benefits of the patient, and then that's to the detriment of things which we do which perhaps are much better. And I think if the people coming along to have those tranche of tests and investigations and appointments were a little bit more aware about their potential value or even lack of it, they might be a little bit more circumspect about wanting money spent in that way. And I think they might be keener to have the money diverted into things which have a much stronger evidence base. It is difficult. There is a finite amount of money that can be sourced from taxation. There are other ways perhaps to try and top that up by making it easier for people to top it up themselves or to make choices or to contribute. There are, if you like, two health services. There's the state-funded one, and 10% of the population have access to private healthcare as well. Perhaps we should encourage people to take more responsibility, and if they can afford it, maybe they should have to pay more. I don't know. It's very difficult because you run into all kinds of political dogma with if everybody can't have it, then nobody should have it, and it's very difficult to try and break that barrier down.
Yeah, Stephen Durrell used to make the point quite interesting, or still does make the point interestingly, I expect, about there is no a country deciding to spend more on healthcare or social care is a positive thing. It's the only problem is funding it through taxation. But yeah, Alex.
Yeah, I mean, so on this sort of health social care funding, we absolutely need to see this as one system, because it's fantastic that the government is protecting healthcare spending. It's absolutely vital. And the impact of it will be hugely undermined by the collapse of large sections of the social care system. The home care industry is in free fall. There are places where it won't exist. State-funded home care for older people will not exist in a few years' time. And it's already showing up in NHS waiting times and A&E and all the rest of it. So it makes no sense to think of those two things separately. On personal health budgets, we've had personal budgets in social care for about 20 years. And when they first came in, so direct payments legislation, there was a very similar reaction from the powers that be and sections of the media about that people would be squandering. People couldn't be trusted with this money. Disabled people would be squandering this money on all sorts of frivolities. For some reason, leather trousers always came up. There was somebody kept going about how they'll spend it on leather trousers. People didn't spend it on leather trousers. This was vital care. Now, people, which isn't to say that every penny has been spent brilliantly, but there is no system in which every penny of public money is spent brilliantly. So if that Wii Fit or whatever it was that was bought, which was intended to kind of give somebody some exercise, turned out to be a duff idea, then we've wasted £150 or whatever that cost. But Winterbourne View wasted millions of pounds and quite a few people's lives. We can talk about examples of public money being wasted in the health and social care system, which runs into billions. So I think we need to set that kind of risk in context. And the good thing about personal budgets is that the risk is actually relatively small, because people don't have very large amounts of money to play with. And people take that pretty seriously, but it comes back to, I think, John's point about sort of it's informed choice. So actually, if you don't give people the support that they need to think through everything that's out there, then they might not make great choices with it.
Can I come in there as well? It just got me thinking about if we're talking about thank you preventative and taking responsibility, should that also be in the adult social care as well? I mean, why should it should just be about general health and the NHS? I mean, I personally wouldn't want to see my own mother going in a care home, really, and I'd do everything I could to ensure that I can sort of keep her with myself, really. So I think we do need to look on the bigger scale, adult social care and every aspect and policy area across the whole spectrum, personally. It'd be interesting to hear both of your views.
Just on that sort of family care aspect, most social care is delivered by families, so the value of social care is many times the value of state social care. So at the moment there is no danger of families not doing that. There are some families who may choose not to, but actually the state is very much the junior partner and always has been in social care. So it's probably, I'd say, the responsibility is on the state to think about how it supports families to do that without breaking families as we do at the moment.
Okay, John.
It is interesting about families taking responsibility for their older relatives. Society today is a lot more mobile. Gone are the days where the children live in the same area where they're brought up, and they maybe live and work on the other side of the country to where their parents are. Are you going to uproot your elderly parents to get them to come and live next to you, away from their social circle and friends? It probably isn't the best way to do it. I think the problem is that we are so used to the state being there to provide the care that we've just taken it for granted, and we just assume that, well, local social services will sort that out. They'll go into a local nursing home, it'll be funded somewhere along the line. I'll see my mother once, twice a year. I'll see them at Christmas and think, oh, she's not very well. Change the what? Better take her to hospital. She's probably been like that for months. It's very difficult. I mean, I work in a part of the country where we have a very elderly and a somewhat deprived community. I also work somewhere where we've got 2 hospitals, one of which needs to close, but there's been too much politics for that to happen. And we're also in inadequate trust as of a few weeks ago, when I'm proud to work for it. But it is very difficult, and I think society somehow has to have these difficult conversations and come to terms with how it wants to do it and how it wants to pay for it. We are going to have to bite the bullet. We are going to have to pay more because demands are going up, and that is not going to come from taxation.
Okay,
It's the best rule in the world, and it's not going to come from the magic money tree either.
Question.
I was just going to talk about I work for social care, a charity that supports unpaid care to people care for ill or disabled family members and loved ones, and for 6.5 billion people in the UK who care and pay for people. So it's, in terms of social care, it's about also supporting people that already care for others.
And show that we value their contribution to society as well.
The
Yeah.
right support.
Yeah.
There's more people caring, more people caring for over 50 hours a week. It takes a tremendous toll on your health, your well-being, your personal life. So, the social care system should also be there to support those people and let them continue caring. Because ultimately, that's what people want their friends and family to care for them, but they also need the support from the social care system.
We have to make it easier for families to be able to do that.
Yeah.
Whether it's more flexible working or some kind of tax incentive, it has to be easier for them to do.
Definitely, I agree with that.
Okay, yes.
Caroline from ResPublica Foundation. You've spoken quite a bit about innovation and the importance of innovation. Lots of charities, particularly smaller charities, have traditionally been very good at that, particularly when they've had grants and had the freedom to do it. Grants to charities have been going down, and it's increasingly through very specific contracts which don't allow that kind of innovation. It'd be good to get your thoughts on how do you balance that drive to decrease unit costs whilst allowing flexibility for organisations to actually try new things and discover new approaches that could be more effective.
Andrea.
I didn't hear the last part of the question, so
it's how you balance that ability or balance that drive to decrease unit costs, which are doing through contracts, with that ability to give organisations the freedom to try new approaches and things that could actually be more effective and cost efficient in the long term.
Well, first of all, do grants always have to come from some, political or like government body really, or can we sort of tap into businesses really? I mean, I'm involved in a small charity, MRSA Action, and everything that we do is all through fundraising ourselves, and we don't get any grants. It's just run purely by volunteers. So I do think it's the same when we're making savings in areas of public sector really. It is an opportunity to innovate, and I do think we need to give you the flexibility to come up with new innovative ways, which and especially for sharing best practice. And if you do come up with something, then let's share it, and then if that's worth adding some funding into it, then that's the way forward.
Yeah, Alex, I guess you experienced that.
Yeah, and there's a review going on at the moment of the voluntary community and social enterprise sector's role in health and care, which is looking at exactly this question. As you notice, Lloyd's Bank Foundation has been a good partner in that. And what the voluntary sector organisations are telling us is that there's this increasing battle between their mission, which was often set very close to or by community, and what the work that they actually have to do as they chase contracts which are set elsewhere. We need, I think, to move from a view of the voluntary and community and social enterprise sector as an occasional contractor and a fairly disposable contractor that does the extras that are nice if you can afford them, but have to go by the board when times are tough, to recognising that there are organisations out there that are doing absolutely essential work.
Macmillan as well.
Exactly, yeah. And that also have a real role in planning our health and care system. So there are one or two areas where actually the voluntary and statutory sectors work together with people to plan their health and care system, which means that the voluntary sector is then challenged in terms of delivery around the things that it's had a stake in, and goals which look much closer to what they're actually good at. And it usually leads to a more holistic view of what the system is trying to achieve, which also helps to address some of those tricky questions about do you close hospitals or not, because actually where people do get their citizens involved in those questions in a really informed way, which is what we describe as co-production rather than consultation. In other words, sitting down at a blank sheet of paper stage and saying what are we all trying to do here and how can we get there. People can have some pretty grown-up conversations. The public is aware that money is not limitless, and that we don't all dream of spending time in hospital. We would much rather be supported at home if that's a viable possibility. But I think too often we consult, we make a decision, and then we say, what do you think about closing this hospital? That's when people start chaining themselves to it.
It's not something I have any particular expertise in, but I think we're going about it the wrong way. Rather than delivering a one-size package of social care because that's all we can do for an individual, it isn't necessarily what that individual needs. And I think we need to have a greater discussion and dialogue with the individual person about what is it you actually want us to do? How can we make that work better for you? This is how much it's going to cost. Is there another way in which we can provide you with the care and services you need, which doesn't necessarily keep you in this place? Or maybe we should think about other solutions which you haven't thought about, and trying to facilitate that discussion. To try and get people more aware about how much it costs to have somebody come round 8:30 every morning to get you up and get you breakfast. Maybe that's not really the solution. Maybe that isn't if you've got people who are socially isolated, maybe getting rid of that social isolation will mean that you don't need to send somebody around for a rush 15-20 minutes to get them out of bed in the morning. It's a very difficult problem.
You're describing a really good personal budget process to some extent, which I think we actually should be embracing for people with long-term conditions in health, because personal health budgets aren't about have a voucher rather than see your GP. They are about people who are going to have a very long-term relationship with a health service, which is very complex, which is very intrusive necessarily, takes a big part in their lives, and where their expertise in their own lives is hugely important and often undervalued.
I think if you can say, okay, well, it's going to cost this much to get somebody coming around for half an hour every day, but if we spend it in another way, maybe you have to make compromises, and maybe you'd be better off if you're given different choices. When it comes to closing hospitals, again, to go on about that, but if people said, okay, we want to keep our local hospital open, you say, okay, well, it's going to cost you this. We'll do it, but it's going to cost you a lot more. Are you prepared to pay that? Are you prepared to suffer the consequences? Because it's your choice, it's your decision. If you want it to stay open, fine, but you're going to pay for it.
Do you sense, Andrea, you're sort of engaging with people sort of day to day on these kinds of issues? That there's an appetite to have, what would be extremely difficult conversations, not just about closing hospitals, but about do you want us to kind of serve up the value of the things that we're giving you, or charge you if it's your sort of personal.
I don't think there's
decisions.
an appetite for change, if I'm honest. I think there's an appetite for people who want more and more out of our health system, our health service, and. So it is. I think it's going to be a good generational change in people's mindset. Really.
There's a lot of people who are very afraid as well. I think that there has not been trust under either of the any of the last sort of 3 governments or so. I think neither left nor right has been very good at trusting people, particularly trusting people not to act purely out of self-interest, but to act collectively. And I think that's what we really need to change.
Okay, is there another question out there? Okay, we're coming towards the end of the session, so I wonder if we could round up. I'll sort of attempt to bring those things together, some of the things together in a moment. But I think you sort of, Andrea, sort of hits on a sort of particular issue there about this. There is not a strong, easy appetite for some of these changes. And talked about the fact that we're going to need a sort of generational development to shift that. I suppose one thing I'd sort of raise is that the sort of the cost problem is now, and the fact that we can't, there's not a willingness to fund the growing demand in care is sort of here right now, and so how do you bridge that gap to the generational change financially? And the sort of all the kind of fairly graphic consequences that are probably going to come with that in the next couple of 2 or 3 years, and also what can we all do to sort of we've talked about already some good suggestions, but is there sort of one final thing we can suggest to do to help bring about that generational shift in our different roles?
Is this a question or summing up?
This is a summing up with
right, okay.
those options available to you.
Okay, a bit confused there. Well, I think what's come out of this evening for me is we all come from different backgrounds, but there's a lot of common themes. And I think one theme is, especially with yourself, really, is consequences. I don't think we're very good with the NHS. Putting out there to the general public, look, this is a consequence of you with your current lifestyle at the moment, as an example. And also, I think it's also putting my sales ex-retail hat on. I think it's explaining to people what's in it for them. The only way you're going to get a lifestyle change is if people realise what is in it for them. Which ties in with consequences, but they can actually visualise themselves in the future and realise that they're going to benefit from it. I found it quite a fascinating debate this evening, and I think we all agree about being future focused, which is interesting. I liked your way about having an integrated system in the community. When I leave here, I'm going to Google about leather trousers. And I secretly wondered if you've been a rock band or something. Yeah.
It's not safe for work.
I saw leather trousers when I was in a rock band, actually. But
That's the next question.
But I do think, sort of summing up, it is collectively, it's every one of our responsibility in this room, really, in the future, for not only taking control of our own lives, really, and our own health and well-being, but also those of our loved ones, and sort of promoting that in society, really. So I think the third sector can come together with politicians, with business, with the likes of the NHS and medical professionals, and I think, and the general public, really. It's something that we've all got to pull together on, and I think it can be quite an exciting time, really. And this has got me sort of thinking. I set up an all-parliamentary group for patient safety among the Patient Association, and I wondered if the company you work for, or ResPublica, or something, would like to provide a secretariat, and I don't mind chairing a group on looking at preventative. And actually, let's cross parties sort of work and do some work on because I think we need to put it on the agenda now, not tomorrow. We've got to put it on the agenda. But thank you, and it's been a very interesting debate.
Okay, thanks. So, John, your summing up thoughts?
It's encouraging to hear that there is a lot of common ground. I think there is an increasing willingness to face up to the problems. We're all aware of the problems. I don't think we can kick it down the road any longer. We are going to have to do something. And as somebody who is relatively apolitical, it would be really nice to have the politics taken out of the debate and get rid of all of the shroud waving and all the anti-privatisation, or let's save the NHS. Let's try and consign that to history and face up to realism. But also we've got to get the public to take a much greater responsibility for themselves and to be much more aware of the consequences of their actions and to understand where the money's going and how it's going and what it's being spent on.
Okay, Alex.
Okay, so I'm comfortable with the discussion around consequences and responsibility. I think we have